Fuck. Hi, John.
Good morning. Can you hear me okay?
Hi, John. Morning.
Oh, okay. You can hear me okay?
Yeah, I can hear you.
Oh, it's a nice background.
Oh, thank you. Don't worry, it's a virtual one.
That's in your office?
No, that's a virtual background.
Nice.
Sorry about the lighting, it's a bit poor, isn't it?
Oh, that's not really your background. That's
Yeah.
okay. Yeah, it's like mine. It's like a picture, a photo. So how are things going?
Going okay, John. You know, it's the same, not much of difference.
Yeah.
Bit
Okay.
busy these days. I didn't have much time actually to get through these slides also, so a little bit of hiccups, but I think should be okay.
Well, I think I have a spine surgeon that will do a webcast with you from Florida, from Tampa. He's very enthusiastic, and I think he'd like to do it. So
All right, that's
we'll
great.
talk about that later.
Sure.
So
how are you doing? How are the things?
good.
You're busy?
Good.
Busy as always, is
Getting
it?
very busy. I got six webcasts in over the weekend.
Oh, is that so?
Yeah, that's slowly getting stronger. It's a slow road. It's a slow
Yeah.
road, but it's working. People are accepting this as part of education now.
Of
They're
course.
accepting it.
Yeah, I think you're doing a great job.
Yeah, before I had to basically convince the doctor to do it.
So can I ask you a question? How did you, come to the neurosurgical field? Like, I'm sure you are not a neurosurgeon, is it?
No, I'm not a neurosurgeon.
So
because I ran into people that were receptive to the idea, neurosurgeons that were receptive. And so I went that direction. I could have went cardiology. I could have done dermatology. But, really, when I analyzed it, I think neurosurgeons are open to technology. They're open to it. Their mind is open to it. And this is a new technology. So they thought, well, why not? Why not? And so if you examine the specialties on the internet now, I think neurosurgery is ahead of all of them. It has more webcasts than any other specialty. I think it's because of the mindset of a neurosurgeon. They're used to thinking three-dimensionally all the time. So I think that's why they say, well, this is okay. Let's try it.
yeah, I think you're doing a fantastic job, because that's why like people like us, here on the screen. Otherwise, I don't think that we could have got a chance to deliver a webcast like this, most probably.
Yeah.
At this early age. Right.
Yeah,
How much time we have got, John?
Definitely different. This specialty is definitely different.
Yeah. So I think it's the most competitive subspecialty in the world.
Yeah.
I think neurosurgery.
Yeah. Yeah. We're going to see things develop within this platform too, with 3D and everything else. But basically, it televises the basics of neurosurgery. I mean, nothing new, just basically evidence-based neurosurgery is most of us, 90%. The rest is fine, but I think most neurosurgeons really aren't interested in virtual reality, and because their practice, they don't use it. And some of the equipment is expensive. So it's just another luxury that I think most neurosurgeons really don't need, especially spine surgery, augmented reality and stuff. It's going to be a while before you adopt that, the learning curve, etc. But that's going to be a popular item, I think. Learning online is augmented reality. In spine, especially, I don't know why. It's really advanced in spine, augmented reality. People from Brazil, I've seen, they superimpose the image, and it's. Have you ever tried it? Yeah. Okay, Mohammed. Yeah, someone just remarked on what we're saying. I don't know if Mohammed's. Mohammed, are you a spine surgeon? Mohammed Fahmy Zaid, I believe he's from Egypt, but I guess maybe he can't talk. But he just remarked that got a couple minutes.
Hello?
Hey, Mohammed,
Hello?
you can talk.
Okay, actually, I am a skull-based neurosurgeon. You are asking about the type of my subspecialty on neurosurgery.
You're in Egypt, right?
Yes, Alexandria University, Egypt. And I have visited so many countries all over the world, including, of course, US with the great Professor Osama Al-Mufti, and in Germany, Professor Majid Sameh in Germany, Hanover.
Oh, okay.
And on Japan, Professor Kawase. All of these big professors actually are skull-based neurosurgeon. All of them, of course, is a professor on neurosurgery.
Oh, okay.
And actually, John Banetta, you are one of a group of Egyptian Society of Brain and the Skull. You are a member of this group already. You know this.
Oh, okay.
Okay, and actually our group is enlarged by the activity of Professor Salim Abdel Raouf in US, and Dr. Sameh, he is also from Egypt, Dr. Sameh Morsi from Cairo. He is also one member of the WhatsApp group, Egyptian Society of Brain and the Skull. So it is enlarging the activity of online education on neurosurgery, which I guess it will be the future for any way of medical education and the learning, especially after this era of COVID-19. Does not compromise the in physical conference and the meeting, I mean, because physical meeting have a special effect on learning, like on hand-on, on the microanatomy, neuroanatomy, I mean on neurosurgery, still exist later. but for changing or sharing the knowledge and the data, especially on operation and the experience, it will have a great help for worldwide education, I guess. Thanks, John Bennett, for your effort. You're making all the worldwide neurosurgeon as one group, easily for communication and exchanging the idea. And maybe later, I guess we have the idea about case report and making general worldwide consultations for some of difficult case. Maybe through one of your channel on Neurosurgical TV, we can arrange this with a different nationality from all over the world.
Well, it's a pleasure. And like I was saying to Sarath before, neurosurgeons are open to new technology.
Yes.
The one specialty that I've seen that they seem more, generally speaking, they seem more open to new stuff.
Yes, I remember one statement by Professor Kawase on Japan, but he is also toward the neurosurgeon. He always say most of the neurosurgeon should be genius.
Yeah, okay. Well, I think
so that is why the neurosurgeon are open to the new technology. Thank you.
Yeah, we're going to do a webcast with Sarath and an American, hopefully an American back surgeon.
Yeah,
they're gonna compare problems on how they handle it in their particular countries and compare them, right, Sarath?
And we have a good neurosurgeon and spinal surgeons, I mean, from the neurosurgical specialty under subspecialty of a spinal surgeon in Egypt also.
Oh, okay, we'll have to have him come. Okay, Sarath, are you ready?
Yeah, I'm ready, John. Yeah.
Okay, let's go. 10,
Right.
9, 8, 7, 6, 5, 4, 3, 2. Good morning. This is Dr. John Bennett, broadcasting from Miami Beach, home of Neurosurgical TV. Today, we have the pleasure of having Sarath Munitsinghe, a neurosurgeon from Sri Lanka, who's done a few webcasts before. And we're going to explore the webcast further. We'll talk about that later. But let me introduce Sarath and let him get going. Good morning, Sarath.
Good morning, John, and good morning, everyone, or good afternoon, wherever you are. So this is the, I think, fourth Sri Lankan Neurosurgical Grand Rounds. And today I'm just talking about only the spine cases, and I'm going to review those very quickly. So these are the cases which I have done during the last 3 months only. So I'm only going to discuss these cases due to the time constraint. So let's start the proceedings. So I'll share my screen with you. Can you see my screen, John?
Yes, I can. You can make it bigger, right? Yeah,
Right.
See. Yeah, perfect, perfect.
Right.
Okay, perfect.
Right. Okay. So this will be our agenda. So we'll first discuss about the emergency cases. So I have classified into cervical, thoracic, and few thoracolumbar emergency cases, basically the fractures. And then if we have time provided, then we'll discuss few of the interesting cases of routine category as well, some tumors and degenerative cases. So I think I have presented this earlier as well, and I'm sorry about this because these are the challenges we face every day as peripheral neurosurgeons in a third world country. So I believe that this discussion would be more appropriate for people like, especially young neurosurgeons starting their career in peripheral parts of the third world countries, like India, where the circumstances are similar to my country, and also neurosurgeons in Africa. I know they are working with poor resources and a very limited capacity. So actually, I don't want to waste your time and my time going through this again, but just a few words, because this is very important. I need to tell you this because when you go through the cases, you will see it's nothing extraordinary there, nothing special or nothing important, not hi-fi stuff. This is basic. But why is it important is I have done all these cases by myself alone, and with these limited facilities, with the poorest of facilities, because my hospital, Ratnapura, although it's a teaching hospital, the neurosurgical unit is relatively new, more than 2 years, you can say relatively new, but the infrastructure has not changed since the day of its beginning. So these are the problems we are having. So I don't have an emergency theater. So I may be the only neurosurgeon in Sri Lanka who is not having an emergency theater facility, which is very pathetic. And the lack of the theater time, because I'm having only the operative time from 8 a.m. to 2 p.m. from Tuesday to Thursdays. So out of that time, I have no available theater because of lack of manpower, especially the anesthesia cover, as well as the nursing staff. And no MRI most of the times, but we got a new MRI recently, 2 months back, which is an asset to my hospital, I suppose. And then lack of ICU and HDU facilities, which is universal nowadays due to the COVID crisis. So the other ICUs has been converted to COVID ICUs. So no more ICU facilities available. And so the patients have been sent prematurely from ICUs to the wards or directly to the wards after major surgeries, and they die of aspiration, post-op chest infections, and even the patients sent to ICUs, they catch ventilator-associated pneumonias. So I had to come across several of these cases within the last few months. I have operated for 5-6 hours, but ultimately patients been sent to the ward and they die of aspiration, wasting everybody's time, everything. And also the lack of instruments and accessories. For example, in my hospital, I don't have pedicle screws. I'm just having very few, maybe 10, 15 pedicle screws of just one size, 6.5 millimeters. So all the cases I'm going to show you been paid personally by the patients, and they bring the instruments, so I do the surgery, which is not quite practical most of the times. And also regarding the post-op management, problems with post-op management, rehabilitation, lack of trained staff, no doctors. I'm just having only one medical officer, not a trainee, just a medical officer, and 2 house officers released recently. So not much of support for me and experience for me, although they are very good and working very well. And also the limited bed capacity at the wards. So as a neurosurgeon, I don't have a separate ward or a unit in my hospital. So we used to stay in a corner of the orthopedic ward with 5 male beds and 3 female beds. So that is the situation. And also things add up when the quality of the resources available are also poor, for example, the CR. So in my practice, I have set several principles, because when you work in an environment like this, I think you should first try to survive. First, do not do any harm to the patient. That's the #1 policy. That's my most important policy. Do no harm to the patient. If your procedure harms the patient, don't do it. So these are few of those. Identify the injury or the pathology with the available resources. This is related to my talk today. So for example, say it's a fracture, spinal fracture. Clinical examination is very important. So we should rely more on our clinical acumen rather than the investigations where the resources are limited, for example, MRI. And with that, identify the pathology and identify the treatment options available for you. And then what is the evidence? Search the literature. You must have searched the literature before and you know the evidence. So with all that in mind, and then determine what is the best practical option which suits and fits into my system, into your system and the patient. So that option may not be the ideal one when compared to the other countries. That may not be the ideal, but that option should suit and fit your system, your resources available, and the patient and your patient. It has to be an individualized approach. And always think about the benefits versus risk of the procedure. What is the benefit of doing this surgery? What is the risk of doing surgery? And the most important, can I manage the anticipated complications within my practice? In your setup, you know your resources are poor, your resources are not great. So if some complication occurs, anticipated complication, are you confident enough to manage this patient by your own without transferring the patient to anyone else or endangering the patient's life? So this is important, confident versus overconfident or heroic. So if you are confident, if you have a proper training, if you have had a proper training, if you have seen the complications, if you have done this before, embarking on something maybe complicated is not called heroic or confident, according to my opinion. Right, and also, is the procedure really necessary and indicated? You have to always ask this question, especially when it comes to spine surgery, especially these complicated advanced fixations and all. So you have to always ask, is it really necessary? Because I have seen so many times in my country and in other countries, unnecessary spine fixations, which are not indicated, unnecessary fusions. So always ask, is this procedure going to benefit the patient? And is it really necessary? Is it the correct time? Is it the correct patient? That's why we need to do this surgery at the correct time for the correct patient with the correct diagnosis, the correct procedure by the correct surgeon, which is very, very important in spine surgery, according to my practice. So the cases which I'm going to discuss will be having so many deficiencies, so many mistakes. Some of you will not agree with me. But remember that these cases being done, these cases being performed under very limited resources, limited capacity. And if you want to find out mistakes or deficiencies, you will find out 101 deficiencies of this. But I'm going to tell you how I'm going to survive, or how I'm surviving every day with these cases, with all these problems under the circumstances. So this is the first case. So we'll talk about the cervical emergency cases. 25-year-old female, jackfruit fallen on head during the lockdown season, 2nd of June. This is what she presented to me with. C5 fracture with, I'm not sure whether you can see, there is cord contusion here.
Yeah, did you want to share? You share that? Did you want to share that?
Sorry.
Oh, I'm sorry. I'm sorry. Okay, I'm sorry.
Okay. So you can see the cord edema starting at the level of C3 to C5. So this is according to our classification, A2 fracture. It's a pincer fracture with cord contusion at C5. Bilateral lower limb power 1 out of 5 according to MRC scale, and the upper limb power distal to C5, it's 2 out of 5. Asia C, subaxial injury classification score 5, so which prompted me to operate on this patient without any doubt. So what we did was the posterior decompression and lateral mass screw fixation. So intraoperatively, I noted that there is disruption of the posterior ligamentous complex in this patient. So this was at a time where the MRI scanner was brought, the very initial period. So we didn't have film, so we just got the video downloaded from the console. So this is what I did. So there was a PLC disruption one level above and below the index level of fracture. So I had to fix her from the C3 level down to the C7, C7 level. I know ideally I could have gone down to T1, but this patient, one reason was we didn't have pedicle screws for T1. And also this patient was really, really poor one. So she had to mortgage her house to buy these screws, which is very pathetic because we didn't have these lateral mass screws as well. And she didn't want to get transferred to a different hospital as well. So we had to do this at our hospital. So this is before the surgery. This is the finger movements. And this is post-op day 10. This is post-op day 14. The lower limb power was gradually improving. And this is post-op day 25. She was gradually and promisingly improved day by day. This is day 30 post-op. We kept her, although we had only 3 beds in our unit. So we kept her all the way until discharge, and she could stand and she could walk with assistance and discharge. So I think it's worth taking a risk for her amidst the financial difficulties. All right, so the next case, case number 2, 37 years of age, male, bull attack on 10th of August, presented with C5, C6 bilateral facet dislocation. She's stage 3, you can see, it's a bilateral facet dislocation, more than 50%, with stage 3 in classification. CT angiogram not done, not available because of the difficulties in getting it done as early as possible. Patient was on spinal shock. Bilateral lower limb power 0 initially, upper limb power 1 out of 5, which is distal to C5. And approximately it was 3 out of 5. So this is AO type C. So we did the immediate surgery next day morning. And I think this may be useful for you, the algorithm of management for facet dislocation, cervical facet dislocation. In that case, I had the suspicion of disc prolapse. So I did not attempt closed reduction. And we were able to get the MRI done as early as possible before the next day morning. So this is the MRI, which shows the a large disc herniation at that level, C5, C6. This is the whole spine. You can see the disc herniation there. This is the axials. Again, you can see the large disc herniation. And so what we did, first, as I said, closed reduction not attempted. And it was confirmed with the MRI next day morning. So we immediately took the patient to the theater. So initial anterior approach, as it is confirmed, as it is recommended by this is the AO guidelines. Disc herniation, if the disc herniation present, if it's a bilateral dislocation, usually, this is my practice, I do the anterior approach first, reduction, discectomy first, then reduction, and fusion, plus or minus fusion, then the posterior approach, posterior fusion. So I removed the large disc to decompress the cord, but I was unable to reduce it. So anteriorly, the reduction was unsuccessful. And so I did not fuse anteriorly. I removed the disc. I did not fuse. I will tell you the reason why. Because I didn't have the bone graft to fuse at that time. So but I had the allograft, the cages, but I did not do it intentionally because of some reason I will tell you later. And then we turned the patient posteriorly, and we identified the posterior ligamentous complex is disrupted from C4 to C7 level, and additional pedicle fractures at C4 and C7. So first, I reduced the fracture posteriorly, and then fixed with the lateral mass screws from C3 to T1, because I had to do a long construct because of the disruption of the posterior ligamentous complex at the levels above and below the index fracture. So this is pre-op MRI, as I showed you earlier. This is post-op X-rays. So you can see 2, 3, 4, 5, 6. So it's nicely aligned. And pedicle fracture at T1, because there was the disruption of the PLC up to this level, C6, C7. So I had to include T1 as well without stopping at C7. And so this is from C3 to T1. I could not insert the screws at the level of the pedicle fracture. So this is pre-op. You can see the CT. This is on the left side, and this is on the right side. I think you can see it is nicely aligned. And this is the axial of the CT. Right, this is the reason why I did not do the fusion anteriorly with an allograft. This is the initial chest X-ray pre-op, and see what happens to his lung. This is at ICU. We had to send him to the ICU because his respiration was not good, impaired, which is obvious in most of the C-spine fractures. So whole lung is collapsed on the left side. And our respiratory physician did a tremendous job. So this is after bronchoscopy. And we had to do a tracheostomy because of his lung condition. So he ended up in a tracheostomy. So this is the reason I did not do the fusion with the allograft, with the cage, because I was pretty much sure that without the ICUs at these days, he probably would have ended up with a tracheostomy, and he did. So it's not a big deal. I have already fused him posteriorly. So you can, once the tracheostomy is closed, you can get him back and fuse him anteriorly with the cage and the plate. It's not a big thing. Right. So because I had a few bad experiences, couple of experiences before this case with a similar dislocation. So this is his upper limb power. This is at 1 month's time, maybe 3 weeks' time. But we discharged him. We sent him to the local hospital with the tracheostomy, but he's much better than this. So we are planning to do the anterior fusion as well. But his lower limb did not improve, unfortunately, until now. And this is the third case, 54-year-old male, 30th of June, C6, C7 bilateral facet dislocation, AO type C. MRI was not available, out of order, even though we had that out of order. Don't know why. Lower limb power 1, upper limb power 2 out of 5, distal to C6. Immediate surgery next day morning, 360-degree fixation done, anterior followed by posterior. This is the X-ray. This is the CT. Again, bilateral facet dislocation. You can see the posterior features of posterior ligamentous complex disruption as well. And this is the intraoperative C-arm picture. I'm sure you will see the poor quality of the C-arm. So no doubt that you understand the difficulties I'm facing every day with this type of quality, this type of poor quality images intraoperatively. So initially I did the anterior fusion, so I could reduce the dislocation anteriorly, and I inserted the mesh cage. That is the only cage we had at that time, and plate, ACP plate, and 3-level posterior fusion. But I did the 360-degree fixation at the same time, the same day, because I thought this patient had chance of improving because his lower limb power, although it was 1 out of 5, I thought he would have improved compared to the other patients. But unfortunately, what happened, we didn't have ICUs at that time. We had to send this patient to the ward. The second day postoperatively, the patient died of aspiration pneumonia. Patient got respiratory arrest and he died. So this case is before the last case I showed you. And I was really disappointed doing 4-hour surgery, and the patients on the next day, post-operative day 2, going to the wards and die of aspiration, which is really, really sad. Right, but these are the drawbacks that we face every day, most of the time, right? Okay, those are the cervical spine cases, emergency cases. So we'll move up to the thoracic fracture cases, just only one case. I'll go through it quickly. 54 years of male, road traffic accident, T4 complete burst fracture. This is what he came up with. You can see it's a complete burst fracture at T4 level, compressing the spinal cord. It's a complete burst. So A4, AO classification A4B2. Sorry, it's not N0. It's a complete paralysis. So it's N4. It's a complete paralysis. It has to be N4, right? Not 0. So bilateral lower limb power 0, Asia A. Asia A. Anyway, I had to fix this patient. So it was a difficult case because you can see the build of the patient. He is 6'6" and 120 kilos in weight. So it's very difficult case. Very, very large built patient. And we had a lot of problems in locating the and visualizing the index fractured levels with the CR. So it is obvious with that poor quality CR that I'm not going to visualize that the levels with that CR. So you can see the fractured level. Virtually, you don't see the cord at that level. So, as I expected, the C-arm did not visualize the fracture, so I had to use the freehand technique. So I had to insert the pedicle screws without using the C-arm. So this is without using the C-arm, I had done this surgery. So you can obviously see it's not perfect. Slightly gone through gone past the anterior border of the anterior cortex. But luckily, the CT, it's on the right side, and it has not gone significantly past the anterior cortex to impinge on any vital structure. And it's luckily it's on the right side, not on the left side. So it's marginal. But I think without the CM, I think I have done something better for this patient. So it's a long construct, long segment fixation and decompression done, and we discharged the patient. His power improved a little bit to 1 out of 5 lower limb at the end of 3 weeks' time. So we'll keep following him at the clinic. Right. So this is another thoracic case, thoracic fracture dislocation. 56-year-old male, 6th of June, T56, AO classification C, Asia B. Surgery done within 24 hours. All these patients came to us luckily on a day that we had our routine theater days. So we could take them to the theater next day and we could operate, although we had to postpone all our cases. Anyway, we were only doing emergency cases for the last 5-6 months because of the COVID crisis. So there was no issue of postponing the other routine cases. So you can see again fracture dislocation, T5, T6, significant kyphotic deformity. This is the CT. You can see better the CT. Right. So this is the intra-op picture, because I don't have a post-op picture because patient died, again because of aspiration. So I couldn't take any X-rays. And you can see the kyphotic deformity. This is the fracture dislocated level, fractured level. And I don't know whether you can appreciate this. This is the fractured level which was fixed. And can you see the alignment? We have achieved the alignment. It had to be a long construct because the PLC was also disrupted. So I had to fix tree level below and tree level above to achieve the alignment and to correct the kyphotic deformity. So unfortunately, patient was sent to the ward. And again, the same thing. He was on an NG tube. The day two, post-op day 2. The nursing staff was not very trained at that time because the trained neurosurgical staff was sent to different places due to COVID crisis for the COVID care. So the patient was in a different ward because we didn't have beds in our unit. All were filled, but we regularly visited and we managed the patient, but unfortunately, patient died of aspiration, which is very pathetic and very, very, I don't know what to say. Right, okay. Right, and then we'll discuss about thoracolumbar fractures, which is the main stem of our discussion today. So I'm sure all of you are aware of the principles, right? The classification systems, the AO spine, what the holes were, the McCormack, 3-column Dennis, right? And the mechanisms of injuries, the morphology, you had to look for the PLC disruption, whether they are intact or not, the neurological status, neurology, and the modifiers, and try to achieve the reduction and try to realign the fractures and decompress, fusion or not, with the fuse or not, and stabilization and prevention of further instability. I think these are the key things that you need to look for when you're treating a thoracolumbar fracture. So just to recap, just to refresh your knowledge, this is the fracture, this is the AO classification, ABC. I'm sure everyone knows that. This is the neurological status. So I will tell you a few things about my practice. So in my practice, what I use is I stick to the new AO spine classification and the TLIC system to guide my management decisions. And we always remember, right, when you are working in a periphery and when you are working with limited resources, remember that none of the classification systems are perfect, right? So it is up to you to modify accordingly with the basic concept of the classification systems. And remember, especially when you deal with a group of people which do not have much educational level and ignorant, you have to think about the patient reliability and also the possibility of follow-up when you are managing these patients conservatively. And also in my practice, I have to always think about the financial or the social status of these patients, because most of them are male, the sole breadwinners and manual workers. So they need early return to work. So they can't wait 3 months, 6 months with conservative management, with sometimes with bracing and all. Sometimes it may not be practical, even though it is indicated. So during my workup, we usually get the X-rays almost always. And then CT whole spine, I usually request for a CT whole spine. And I think this is X-ray and CT are essential. An MRI was not available, as I told you, until 2 months back. And according to my view, it's not always necessary, but it's helpful, especially when the patient presents with neurological deficit. And especially when you're doubtful about the integrity of the PLC, posterior ligamentous complex. So if it is available, it is accessible, it's better to have an MRI. But if it is not, it's not a contraindication. It's not an indication to postpone the surgery or not to operate. Right. So these are my surgical decisions. These are my decisions according to which I have made according to the guidelines. So I think everybody will agree. If I say A1 injury, I don't fix them. A2 injury also, just isolated A2 injury, no fixation. Do I brace A1 and A2? Yes. That is mainly for the patient comfort and pain relief, not because it produces so whatever it realigns the fracture, but mainly for the patient comfort. And then A3 fractures, which is quite a gray zone. So if for me, if neurology is present, I usually fix them. If neurology is not present, I prefer to manage them conservatively. If neurology is negative, but there are modifiers, for example, lack of follow-up, the risk of losing at follow-up, or the patient can't wait for 3 months because he's the sole breadwinner, manual worker. Sometimes I consider fixation, not always. Same thing as I told you earlier, risk of follow-up, I fix. A4, isolated A4, usually fixation in my setup. It may be different. You may have different ideas, different opinions according to your setup and workplace. A3 or A4 with B2, definitely I fix, no doubt about that. Right. Okay, then how am I going to fix these cases? Am I going to fix them with short segment fixation or long segment fixation? This concept is very important for me because, you know, I have the problem of lack of accessories, lack of instruments. I don't have screws as free as I like. So patients bring them, they are poor, so it's limited. So if it is possible, I always try to go for a short segment fixation unless it's indicated for a long segment fixation. For example, isolated A3 or A4, I prefer short segment fixation. And when it is A plus B2, when there is PLC disruption, I usually go for a long segment fixation. And I believe in short segment fixation, one screw at fractured segment is enough most of the times. Right. Do I decompress the canal always? Do I do a decompression of the canal? Do I do a laminectomy? The evidence is, although the surgical clearance of the canal does not affect the neurological outcome, in my practice, I do perform a decompression when the neurology is both incomplete and complete. That is my practice. But you can argue either way. Then, is it anterior versus posterior approach? The literature says no difference in terms of neurological recovery, return to work, Hobbs angle, complications between the two approaches. But I prefer posterior approach, not because I don't like anterior approach, not because I don't know how to approach fast anteriorly, no, because less resources for anterior approach, because it has higher cost and the operative time. I have limited operative time. Sometimes I had to do two long segment fixations within 6 hours, plus another case like a VP shunt or a cranioplasty or ICH evacuation. So it's very limited. So I think for my practice, these are my principles. And do I consider a combined approach or when? I consider combined approach when AO type C fractures with incomplete injury, fracture dislocation with incomplete injury, and also fracture dislocation with potential for neurologic recovery. For example, I have a patient, I'll show you, fracture dislocation, initially complete injury, but he's recovering. So in that case, I might consider going for a combined approach. Right, fusion. When to do fusion? Am I doing fusion? Usually do not, except AO type C, when it is indicated, absolutely indicated. Right, so we'll go through the cases very quickly. This is the first one, 28 years old male, fallen from height. All these lockdown season, 13th of last month, 40 feet height, coconut pre-climber, extremely poor people. T11, 12 fracture dislocation, bilateral lower limb power 0, Asia B, AO type C, TLX 8. No doubt you're going to operate on this patient. Long segment posterior fixation plus fusion, as I told you in the discussion before. So this is the CT he came presented with. So you can see the fracture dislocation clearly, T11, T12. This is the MRI. Severe cord compression. And this is what I did. So 2 levels above, 2 levels below. I think this is the maximum reduction of the alignment I could achieve. And I think it's a reasonable one, considering the pre-op measures, because the instruments I'm having are very, very limited. So with that instruments, I think I'm doing my best. Right. This is the patient I told you. So he's recovering. Now he's almost 1.5 months, as I can remember. And he's gradually improving. His lower limb power is 2 on the right side and 2 on the left side and 1 on the right side. So I might consider going for the anterior approach later. And I don't know whether you can appreciate the bone graft here. So I applied the bone graft for the fusion. I removed the disc, and because there was a big disc at that level, I removed the disc and I fused the level. I don't have these cages, thoracic cages for fusion. I didn't have at that time, so I did not consider it. Right. The next case, 24 years old male, again, coconut tree climb. So this is what they do. They climb the coconut trees and pluck the coconuts for the other people. And usually their daily income is around maybe say 500 rupees, which is around 2.5 US dollars. And they fall from the coconut tree. And when they come to the hospital, they have to pay for the screws, 8 screws and 2 rods. 1 screw is 20,000, which means 100 US dollars. So it's their 1 month's income, total income. So how can they afford 8 screws and 2 rods for a patient like this? So these screws were inserted with the generosity of that company. I personally asked for them because that patient was very poor. To offer them a free screw, they offered. So until now, they have been very generous, very good. And apart from that, we used a few of our screws available, 6.5 screws, which were available at the hospital. So this is how we manage these patients every day. Right, okay. Again, this patient, coconut tree climber, young one, T12 burst fracture, right? You can see, I hope you can see the, it's a flexion distraction injury with the disruption of the PLC. You can see the interspine is widening there, which indicates the PLC disruption. So it's AO classification A3, it's incomplete burst, A3, B2, N4, complete injury, Asia B, lower limb power 0, TLX 9. So as I said, surgery, again long segment, posterior fixation. This is the X-ray, the CTs. You can see the CT. You can see clearly the fracture line goes through the bony, the complex as well. This is the axial, a bit of shattering. And this is the MRI. You can see compression of the cord, mainly on the right side. Whole spine MRI, same patient. This is what we did. So long segment fixation, including the fracture level. I usually prefer inserting at least one screw when it is possible, unless the pedicle is fractured to the fracture level, because it aids in a better realignment. And the kyphotic deformity is reduced. I couldn't insert the screws at this level because of the poor bone quality. And this is the CT. I hope I understand, I mean, the realignment is not 100% correct, but with all the armamentarium I had, this is what was possible. And this is him, slightly improving, slowly improving, promising. Okay, case number 3, 20 years, fallen from height 30 feet, Jack 3, 11th of August, L1 burst fracture. L1 burst, you can see. Sorry, A4, it's a complete burst. B2, the posterior ligamentous complex disrupted, and again N4, complete injury below the level, Asia B, TLX9, again long segment posterior fixation, done. So this is the MRI at that time. You can see severe compression of the cord. Right, this is what we did. Again, long segment posterior fixation, including the fracture level. I included the fracture level as well because as the pedicles were intact, and I could not incorporate the pedicle screws to the above level because of the poor bone quality. So this is actually, I mean, this is usual finding in our practice. Poor people, they are, even though they are young, most of the times the bone quality is very poor. This is him. He did not improve, and he didn't come to the clinic recently. So I'm not sure how's the status at the moment, but 1 month back, his power was the same, the lower limb power. Right, case 4, 18 years of age male, fallen from height. All these are fallen from height. 31st of August, again T12 burst. C, T12. Burst fracture. Burst fracture. Posterior cortex gone. Involved, sorry, posterior cortex involved. AO classification A4, TLX7, bilateral lower limb power 3 out of 5. And we planned for short segment fixation, but intraoperatively we found that the left L1 pedicle was fractured. This is the MRI. I'm sure you can see a bit of cord edema here. Bit of edema there. This is what we did. So the fracture segment is included, just one screw, and the level above and the level below. Right. Yeah, I think as far as I can remember, the fracture was not at the pedicle, The fracture was at the PLC. Yeah, intraoperatively there was a PLC involvement, just the supraspinous ligament or the interspinous ligament at the L1 level. So that's why I extended the fixation, the level of fixation one further below. Usually I don't extend the fixation caudally. If I extend, I usually extend the fixation cranially rather than caudally. Okay, case number 5. 34 years of age, male, fallen from height, again 12th of August, T12 burst. T12 burst. You can see the burst there. MRI, few cord signals. And that's why his bilateral lower limb power was 3 out of 5. So this is a complete burst, A4, B2. Because there were features of PLC disruption pre-op as well. Clinical examination, there was interspinous widening step and incomplete injury. TLX classification 8. So A plus B, posterior long segment fixation was planned. And this is what we did. Fracture was not included at that time, on this occasion, because it was not feasible, not possible. Usually I like to angulate my screws medially for lumbar fixations. And for thoracic fixations, I prefer less angulation medially. And you see the length of the it's not ideal. Yeah, the screw, the length of the rod, the positioning was not ideal at that time, but it doesn't matter. It's not a big thing. These things happen, right? Okay, this is him. This is after 3 weeks. He couldn't walk initially, and now walking with assistance. Okay, he was sent to the local hospital, and that is at the local hospital. Case number 6, 54 years of male, 1st of September, fallen from height. 5, 4, 3, 2, 1, L1 fracture, incomplete burst. A3, B2, there was PLC disruption, incomplete injury, bilateral lower limb power was 4. TLX 8, indication for surgery. And I did long segment posterior fixation. Extremely poor patient. This patient was extremely poor. You can see it goes up to the posterior cortex, involving the posterior cortex, so it's a burst. It's an incomplete burst. Right, it's only involved the superior cortex, the superior end plate. This is what we did. Right. We used the screws which were available at the hospital because this patient was extremely poor. He even did not have enough clothes to wear. He only had 2 sarongs for all the time since 1 year. So could not afford even the clothes. Just only had 1 sarong, which is a common type of cloth worn by Sri Lankan males. It's pathetic. And he could walk. This is post-op 1 week. He could walk with support, and we discharged him. Improved a lot, and now he's walking after 3 weeks' time. Case number 7, 59 years of male, 6th of June, L1 burst, MRI not available at that time. This is the fracture, you can see. So it's an incomplete burst with the disruption of posterior ligamentous complex, TLX 8, indication for surgery, posterior long segment fixation done, right? Posterior long segment fixation done, excluding the fractured level. Again, the bone quality was poor at some level, at this level, so could not incorporate, could not cannulate the pedicle at that time. Initially could not walk, even stand up, and yeah, difficult. This is 2 weeks post-op, and now he's walking. He came to the clinic walking alone. Case number 8. 44 years old male, 16th of August, incomplete burst, L1, incomplete burst, yeah. Right, A3, incomplete neurology because he had bladder dysfunction. Although his lower limb neurology was normal, TLX 5, so again, 5, more than 4, I opt for surgery. So we did short segment posterior fixation and his neurology settled in 2 weeks' time. I'm sure you can see the code signal here at the fractured level. So short segment fixation. This is not because I don't know how to measure the length, because the company person didn't have enough lengthy rods, so I had to make sure it's just enough to serve the purpose. So these things happen when you are poor in resources, but still it served the purpose, I suppose, right? What is most important is the outcome. That is the most important principle in my practice, whatever it is. If patient's outcome is good, it doesn't matter whether you are, it doesn't matter the number of fuse levels or the Cobb's angle or the degree of kyphotic default correction. What is important is the outcome and lack of failure. And remember, the short segment fixations usually start failing around 1 month. So you had to follow them up and especially look for any failures after 1 month. So you have to keep them follow up as well. Right, case 9, 62, fallen from height, 2nd of September. T12 incomplete burst, yeah, incomplete burst. This is it, right? The axial cuts are not all along down the affected area, so you don't see the breach in the posterior cortex. So it's A3 and incomplete neurology because there was bladder dysfunction. TLX 5. So we preferred posterior short segment fixation and the bladder dysfunction settled in 10 days. Posterior short segment fixation. Okay. Satisfied? Right. Case number 2, 42, male, RTA, 15th of July, incomplete T11 burst fracture. Incomplete T11 burst. This one I selected because the TLX score was 4. It was 50-50 marginal. AO classification is an incomplete burst, and neurology, the patient had radiculopathy, persistent radiculopathy, which was not responding to the medical treatment. And we tried the medical treatment, not settling, the bracing, and then we decided to operate on him. He was a manual worker, sole breadwinner, so I had the low threshold in operating him. So plan for short segment fixation, and he had poor bone quality caudally, so I had to extend 1 level. I'm sure you can see, you can appreciate here, the laminar fracture is there, and some bony segments into the canal, where you can appreciate here, you can see the nerve is compressed. And so this is the short segment I planned, but here the bone quality was poor. I don't know whether you can appreciate. So then I decided to go 1 level below caudally. So I couldn't insert the pedicles at this level. So I had to go a little bit below, one level below. Right. And that patient went home walking without any further residual pain after the surgery. Another case, 34 years, all young people, road traffic accident, 24th of June. This one, again, doubtful one. TLX 4, it's a compression fracture. And see the scan. See, it's, some would say it's a compression fracture, A1, some would say it's a pincer fracture, A2, with the coronal. It's not, yeah, one could say it's coronal split, right? But the patient had, see the MRI, you can see there is some narrowing here, right? And some narrowing there, and some cord signal. If you clearly, if you carefully see here, cord signal, and possible disruption of the ligamentous complex on FLAIR images. So, and also his bilateral power was 3 out of 5. So total TLX score was 4. 1 plus 3 was 4. But I decided to, considering all these factors, I decided for a short segment posterior fixation. And this is the posterior short segment fixation. And we included the fracture level as well because the pedicles were not blown out, pedicles were not broken, intact. And I had to go one level up cranially because of the slight contusion and damage to the interspinous ligaments at that level. And his initial lower limb power was 3, as I said, and then he could walk with assistance. This is post-op day 10, and then he came to the clinic recently walking. Right. Case number 12, 40 years of age female, fallen from height, all are fallen from height, 30th of August, T12 incomplete burst fracture, normal neurology. So see, incomplete burst, right? Sorry, I don't have the axial cuts, but it was a incomplete burst with normal neurology, but she had severe pain at the fracture site, which was not responding to medical treatment. Severe pain at the fracture site, not responding, and unable to wear a brace. She was asthmatic, and her asthma was exacerbated, and she said she couldn't tolerate the brace, and also she developed hypersensitivity reaction to the brace material, which is very unusual. I'm not sure why it happened. Although her TLX score was 2, which is the clear case not to operate, but I had to operate on this case because considering these modifiers. AO classification A3 and 0. We did the short segment posterior fixation. She was willing for surgery after explaining all the benefits versus risks. And one screw was inserted at the fractured level. This is the short segment fixation. She went home. Immediately post-op, pain resolved at the fracture site. She was a very happy and satisfied patient. Right, case number 13. Fallen from height, 1 year back. 1 year back, T12 incomplete burst. T12 incomplete burst. Almost healing, but a persistent back pain. She had persistent back pain and bladder dysfunction and bilateral lower limb numbness since the injury for last 11-12 months. And MRI showed persistent compression of the corners at the level of T12. Persistent compression of the corners at the level of T12. I'm sorry, I don't have her MRI, unfortunately, which I have missed. So you can see the fracture, and considering the the situation. We decided to operate, and she was willing for operation. And actually, she was asking and she was requesting us an operation after explaining all the benefits versus risk. And we performed short segment posterior fixation, and again 1 level more cranially due to the poor bone quality. So the fracture is here. Short segment was planned, still short segment, I suppose. So 1 level above. Right. And immediate relief from lower limb neurology, which was numbness, to my surprise. After 3-4 days, she was telling me numbness has disappeared and bladder dysfunction, which settled over 3 weeks. And she was absent of any pain in 1 month's post of time. Okay. Case 14, 67, female, fall from height, 16th of July. Background of an osteoporotic spine, L1 compression fracture. It's a compression fracture with a significant kyphotic deformity and intractable pain which was not responding to medical treatment. This is her X-ray. This is the MRI. You can see significant kyphotic deformity with a bit of compression. But her neurology was normal. This is a shot, intraoperative shot through the C-arm. So you can see the quality of the C-arm. You can appreciate it. I hope you appreciate it, how difficult it is for me during all these cases, right? So this is the fixation, posterior fixation, and long segment fixation, because the bone quality, you can obviously see that. No need to tell. And right, so I think it's not 100% correction, but we have achieved a significant correction of the kyphotic deformity as well. She was very happy. Pain was gone, and she went home after 4 days. Case 15, fallen from height. This is on 20th. This is the case I did last Tuesday. So I'm sorry, I think I don't have the CTs of this patient. MRI not available out of 4 days. Bilateral lower limb power 4 out of 5. T12 incomplete burst and L2 compression fracture. T12 incomplete burst and L2 compression fracture. So T12 AO classification A3, N3 incomplete injury. T12 I thought is just A1. And we noticed a step at T12, interspinous widening, querying, suspecting PLC disruption. So according to TLX, this is what we got. T12, we got a score of 7, which prompted us for surgery. L2, it's 3, but still it's concomitant. It's multiple fractures. And we identified intraoperative PLC disruption at T10 level. It's T12 level, at the T12 level. So this is what we did. I usually prefer a short screw and a small diameter screw at the fracture level. This is L2. This is T12. There was PLC disruption at T12. So I went, anyway, we decided to go 2 levels up and 2 levels below. So T12, L1, L2, L3. But since this was a A1 fracture, A1 compression fracture without neurology at that level and without PLC disruption, I stopped at L3 level. So the fixation was from T10 to L3 level. Okay. And patient is gradually improving, still at the ward, gradually improving. This case was done on this Wednesday. 69 years of age, fallen from height, L2 compression fracture and L4 pincer fracture. Let's see. L2 compression, is it L2 compression? Yeah, L2 compression and L4 pincer fracture. See the coronal imbalance here. It's got a scoliosis, a bit of scoliosis here. And you can see the 2 fractures here, right? So the L4 fracture was 1 second. Right, yeah. The L2 fracture was A1 and N3 because he had weakness, bilateral lower limb weakness on knee extension and EHL. So I thought it's due to the fracture at L2, and he had bilateral L5 radiculopathy as well, which is indicative of involvement of the L4 level. So this is the classification we got. MRI was not available. And since the patient was having a neurology, I decided to operate urgently. So the TLX score was 4 for L2 fracture, 5 for L4 fracture. So anyway, I was going to operate, considering the TLX score at L4 level, so which automatically includes the L2 level as well. But remember, intraoperatively, we found that PLC disruption at both the L2 and L4 levels. So that's what I wanted you to say. So sometimes, especially when you don't have MRIs, sometimes, unexpected findings can happen. So I never expected, we usually don't expect an L2 being an A1 fracture, PLC disruption with the clinical examination and with the CT findings, although we did not have the MRI, but intraoperatively we identified. So I had to fix this, the whole lumbar spine, from L1 T12 to S1. Again, he had the poor bone quality. So S1 on the left side, I could not cannulate the pedicle there. So see the fracture at L4, just one screw inserted here. L5, L3, L2, extremely poor bone quality. On either side, I couldn't achieve cannulation of the pedicles. And we went up all the way to the crossing the junction to T12, and all the way down crossing the junction, couldn't stop at L5, went up to S1. And remember, even fixation of single side, unilateral fixation, nowadays, the literature says is as good as bilateral fixation. Okay. Almost 15 thoracolumbar fractures I had during the last 3 months, except the few I have not shown here. And the few two lumbar fractures as well. I'll quickly go through this. Case 1, 58 years of male, fallen from 12 feet height, 2nd of July, lower limb power 4, L3 compression fracture, AO classification A2, incomplete neurology, TLX 4. That's why I discussed here. This is the fracture. You can see the fracture here. Decided on posterior short segment fixation because A2, it's a pincer fracture. Although he had neurology, the TLX score was 4. He was a manual worker. He was sole breadwinner, extremely poor patient. So again, we had to use the few of the remaining screws at hospital. Now it's all over. And we did the short segment. I did the short segment posterior fixation. Right. And you can see the patient went home. Now he's walking. 63, the case 2, the last lumbar fracture case, fallen from height, 30th of August, incomplete burst at L4. Power again, L5S1 power was 3 out of 5. AO classification A3, incomplete burst with incomplete neurology. So this is the fracture here, you can see. This is what we did. Again, planned short segment fixation. This is the fracture level, one level above, one level below. But I had to go one level further cranially because of the poor bone quality. Now he's walking at 3 weeks time. So almost 3 weeks, yeah, Now he's walking. Last time I saw him in the clinic, he came to the clinic with just his clutches. Okay. Right. So this is tumors. Then we move into tumors. Before that, let me right. Okay. Yeah, I think we have time to finish. So few cervical tumor cases. 44 years of male, 44 years old male with difficulty in walking for 3 months duration. MRI spine, pan spine, identified a tumor at C71, probably a neurofibroma at a different hospital, and he came to me for treatment. This is the tumor. So I resected the tumor, complete resection done, and I did the laminoplasty. So did the laminoplasty. I don't have screws, and of course, actually, we don't need to fix this because just 2 levels of, 3 levels of laminectomy because it was spanning from C5, C6, C7 to T1. Yeah, I did a laminoplasty. So this is the post-op CT with the laminoplasty. So this is the axial. You can see the laminoplasty was done. I don't have these the screws or the plate systems for laminoplasty, so it was just conventional and basic laminoplasty with the sutures. This is the day of surgery. This is his. He had the right lower limb weakness mainly, and this is how he walked. And this is post-op day 3. Although it is too early, he was much comfortable and his pain was absent, and he was much comfortable at post-op day 3 following surgery. And he is 80 to 90% come back to normal at the clinic. Case number 2, cervical tumors. Another female, 54 years, presented with sudden onset of bilateral lower limb weakness and goiter. The goiter was investigated before with FNAC, which came as I2, follicular adenoma, according to the ultrasound and FNAC findings. And the MRI on admission showed the C5-6 metastatic deposit causing bone destruction and cervical cord compression. See the thyroid, large thyroid. Thyroid is very big, and this is the affected level, C5, and you can see a small deposit here as well. Again, this is a previous old wedge fracture, compression fracture. See the thyroid, see the deposit. Most probably it has to be thyroid. Most of the time, see this is the axial, see the cord compression. So she presented with a bilateral upper limb power of 2 and lower limb power of 2 and upper limb power of 1 distal to C5. So in my center, we don't have this preoperative embolization or embolization for these type of tumors. So with the assistance of the general surgeon, we did the total thyroidectomy initially, which was followed by the anterior C5-6 corpectomy and fusion with cage at the same time. And this is what we did. So we did the thyroidectomy. At the same go, we did the corpectomy, the 2-level corpectomy, C5-C6, and we inserted the cage and with the fusion. And then as the second procedure, I fixed her posteriorly as well because the spine was unstable. And this is after the posterior fixation as well. You could see the cage was slightly angulated towards one side, but that's okay. And we sent her for further treatment afterwards. And I will discuss another case, and I think I will wind up my discussion after this. So a degenerative cervical case, I think I thought which was interesting. 54 years of male. So I presented to me at the clinic with severe cervical myelopathy, severe myelopathy. Even he couldn't walk, unable to ambulate. And he had loss of cervical. I don't know whether you can appreciate this, loss of cervical lordosis, right? Loss of cervical lordosis. 1 second. And see the axials. This is the MRI. This is OPLL. OPLL from C3 to C7 levels. And what I did, see the CT, 2, 3, 4, 5, 6, 7. So it's extending all the way from C3 to C7 levels, mainly at C4, 5, and 6 levels. You can see it is not behind the disc, it is mainly behind the bodies. Continuous at this level. And can you see it's all the way down, all the way down. And it looks like intradural as well, intradural. So I anticipated the dural leak. So what I did, I thought ACDF, multi-level ACDF with cages was not going to resolve his problem significantly. But I'm sure you might have so many arguments on this one, right? If you ask from 10 people will come up with 10 ideas, 10 opinions. I believe anterior pathology should be treated anteriorly, even though it's not always true. But cervical laminectomy without fixation will obviously make this patient's condition worse, right? One option was cervical laminectomy plus fixation, posterior fixation, or laminoplasty, or multi-level ACDF, and corpectomy. So I preferred corpectomy. I did C4-6 corpectomy with the allograft. This is what we did. 4 to 6 corpectomy with the mesh cage and the ACP plate. This is the axial. As I expected, it was intradural, right? I tried to preserve the part which was attached to dura, but could not. So it caused him a CSF leak, which I anticipated more than 50% of chance. Explained to the patient. So I had to put a lumbar drain. So the lumbar drain inserted and it settled. And he improved dramatically. And there was dramatic improvement. Again, this patient could not afford the hardware. So it was with my request, with the generosity of the company. Grateful to them as well. So these are the cases I wanted to discuss with you. And let me, 1 second. Can you hear me, John?
Yeah, I can hear you. You're trying to get another slide, right?
Right, yeah, just one sec. Right.
Okay.
I think we have time, is it?
Yeah, we're kind of short on time, but we have a question when you're ready. But
Yeah.
once you wrap up,
How much time have we got there?
we just have a few minutes. I have another conference. I'm sorry.
Is that so? Right. Okay. Right. Yeah. What is the question? Yeah. Let's go
Okay,
to the
okay,
questions
very
then.
good. First of all, I thank you very much, Sarat, for putting all those cases together. This is a valuable learning experience for any medical student, resident, or neurosurgeon to have so many cases presented because, as you know, you can learn from every case. We
That's
had
right.
Kiki Terrell that stopped by. I think he may have stepped away, but we do have a question from a I think a spine surgeon from Germany,
Yeah.
Anita Shug. Did you, on case number 14, did you consider kyphoplasty with augmentation and keeping only short segment posterior stabilization based on your limited resources?
Of course, I considered, but unfortunately, we don't have facilities for kyphoplasty or vertebral plasty in my center. So that's why I did not consider that as an option. Otherwise, it would have been my first option rather than going for a long segment fixation.
Okay, very good. You know, I wish we could take more time, but we're kind of pressed for time because you presented so many good cases. I wish I was I wish I was a student again. To be able to be exposed to this education from my computer.
Right.
It's a very valuable, and this is going to stay on YouTube, so people will be able to refer to it. So, and also I'd like to say that we have planned, it was Sarat's idea to have a webcast with a neurosurgeon from a developed country like the US and compare cases on how he would handle certain cases and how Sarat would handle it. And we're going to be announcing that soon. We're arranging it now. So I'd like to thank you, Sarat. I'm sorry I have to run.
No problem. You are very welcome. That's why I actually rushed through the slides because I knew the time was a key factor here, although I had so many cases. So let's discuss few cases, I mean, at a different time. I have another few cases, spine cases, so let's discuss them later. And thank you very much for the opportunity as well.
Yeah, anytime you're ready. I'm sorry, I have to go. Okay, we'll be editing this and send it to you and arrange the other conference and let you know. Okay, very good. So we'll see you everyone soon. Thank you, Sarat.
Thank you, John.
Okay, I gotta go. Bye-bye.
Bye.